சார் நேம் சதாப்தி வச்சிருக்கீங்க நீங்க சார். Yeah, sir, 11 o'clock, sir.
Yes. See,
Vishnu can start.
essentially, Dr. Vishnu is there and
Yes.
Dr.
Yes,
Saranya.
sir.
Yes, we are there.
I think we'll start to let others join.
Sure, sir.
Okay.
Fine.
Good
Vishnu,
morning,
please
everybody.
start. Good morning, sir.
Good morning, everybody. I welcome you to the 55th webinar of the Clinical Neurology Forum, which is regularly organized by my beloved professor, Professor V. Natarajan. And it's a great academic feast for all the young postgraduates, all the senior people across the state and the country. They are involved in this program. And today we have got two interesting neuromuscular cases. And appropriately, the most efficient neuromuscular person in JIPMER, Professor Vaibhav, my very good friend, is the chairperson for the meeting, and I request him to take over and start the proceedings.
I hope I am heard. Good morning to everyone. Thank you, Alan sir, for the kind introduction. I would have loved that Natarajan sir has also joined. I thank him also and all the organizing committee for organizing this case presentations. These are very important actually. What we learn through a case is more than any lecture, seminar or detailed book. A case teaches more. Uh, I think like that. So today, Dr. Ram is not able to join, but we three will be presenting two cases. And the first case Dr. Vishnu will be presenting is uh, fluctuating neuromuscular weakness in which the AChR antibodies were positive. So can there still be a diagnostic dilemma when you have fluctuating neuromuscular weakness and acetylcholine receptors body are present? Can still there be a diagnostic dilemma? So that we are about to see in the cases. And a small disclaimer, this whole hard work has been done by Dr. Ram, Dr. Saranya, Dr. Vishnu and Manoj. I am just coordinating this all. So let's hope for an interesting discussion. And Dr. Saranya and Dr. Vishnu, please go ahead with your first presentation.
Okay, sir. Thank you, sir. Good morning to all. Today, I am going to present a case. It's a fluctuating neuromuscular weakness with a positive acetylcholine receptor antibody, a diagnostic dilemma. So uh, this case is about a 48-year-old gentleman. He is a salesman by occupation and he's coming from Tamil Nadu. He presented to our OPD with symptoms of drooping of both upper eyelids for 25 years, double vision for 25 years, and difficulty in lifting objects for 15 years. So, when coming to history of presenting illness, about double vision, from his 23 years of his age of onset was 23 years, he started noticing he was having episodes of double vision. Initially, while he was driving, he noticed that he was seeing objects as double, and he was not able to judge the distance or judge the how much he has to go properly because of the double vision. So initially he felt that it was happening when both eyes were open. So he tried to close one eye and see, and he felt that symptoms was improving when he's closing one eye. And initially he felt that these objects was horizontally separated each other, and he tried to close one eye and he started doing his procedures like that for almost 1 month, and he felt this double vision was persistent this all through this 1 month. In next few weeks he noticed that he was also developing some restriction of eye movement so that he was not able to manipulate his eyes in all directions. Along the same time, actually, he noticed he was having drooping of eyelids. One important point to note is that he felt that it was having some asymmetric in nature. So that right-sided, it was more than left-sided. And it was having some fluctuating nature also. So he felt that after sleeping, while waking up in morning, these symptoms was like this ptosis was less. And towards the end of the day, like towards the evening, this dose is becoming more. So even because of this 1 year symptoms, it was going like this. He seeked the medical advice after 1 year. So that time he was started on medications, and he felt actually initially he had some improvement with doses, and he felt the diplopia has also significantly improved. But over the course of like 2 to 3 years, these symptoms didn't progress or didn't worsen and become more or less static. So that he was having some static doses, like right more than left, and some mild diplopia. But diplopia has significantly improved, but mild diplopia was little bit, it was persisting. Towards 10 years later, like after like above 15 years ago, he started noticing that he was having some upper limb weakness also. Like he usually takes some 50-liter cans from the shop and he will come to his home lifting that. Over the time, what he felt is that he was not able to lift that much weight through his hands. In next few months, he felt that he was not able to grip that properly, and sometimes the can tend to fell from his hands. And he also noticed that while he was writing, continuously, if he's writing for around 5 to 10 minutes, he felt that he was having fatigue and he was not able to do that properly, and his handwriting was became messy. So in 2 to 3 years time, he also noticed that he was having some difficulty in lifting the both arms, like that he was not able to take any objects, like he had having difficulty to take objects from the shelves. Almost same time, his attenders, basically his relatives and other wife started telling that he was having some thinning in his muscles of the shoulders and forearm. After that, he also started noticing that he was having some thinning. It was not there previously. And in 1 or 2 years later, he started noticing that he was having excessive fatigue. Like he was not able to do work like previously what he was doing. And even after doing little bit of works with hands itself, he was having great fatigue, and he had to take some rest for that. So these symptoms actually, it was all through these years. It started in eyes, and it progressed to upper limbs, but it never reached lower limbs. Lower limbs was spared, and he didn't give any history of any stiffness or floppiness of limbs, high colored urine, muscle pain or cramps, muscle twitching, difficulty in speech or swallowing, and he didn't had any history of any facial weakness, hearing problems, visual problems, neck weakness, truncal weakness, or breathing difficulty. As I already told, he was only having any motor symptoms. He didn't had any sensory symptoms, did not had any neck pain or root pain or autonomic disturbances and bowel and bladder disturbances. He didn't had any skin changes, dry mouth or dry eyes, joint pain, rashes, hair loss, weight loss or loss of appetite, and no photosensitivity. While coming to the past history, since it was looking like initially when symptoms started, it was looking like a myopathy or like myasthenia kind of history. Thyroid disease very much important. So we asked for thyroid disorder. It was negative. He didn't had any thyroid disorder, and he didn't had any diabetes or hypertension. That 1 year after when he started seeking medication, that went to local clinic and got medication, he was diagnosed to having ocular myasthenia. That time they have done acetylcholine receptor antibody, and it was positive, 2.5 it was, and he was initiated on pyridostigmine. But
Dr.
problem
Vishnu,
with
Dr.
sir,
Vishnu,
sir,
the acetylcholine receptor antibody, what
sir.
type of antibody was it?
Sir,
Was it a
it was
binding? Was it a blocking or a modulating?
binding antibody, sir. Like, we have done, sir.
Okay, fine. I just wanted, because as you know that these three antibodies, the acetylcholine receptor antibody commonly which we see is the binding antibody.
Yes, sir.
This is for the sake of postgraduates, and the other antibody is a modulating antibody, which is commonly associated with the thymoma, and the blocking antibody, which is associated with certain primary liver cholangitis and all. Those are very rare. So normally, you should insist the lab to say what type of antibody and what is the type. This is for the sake of postgraduates. Continue.
So initially, because of this ocular myasthenia diagnosis, he was started with pyridostigmine. So almost 1 year he got pyridostigmine. Even though he started on pyridostigmine, initially he had some improvement in ptosis, as I already told. He felt ptosis was improving, but most of this improvement he felt it was during the initial period, initial time, like 1 or 2 hours after taking medication. After 3 or 4 hours, again he started to having weakness. Symptoms again started to come back again. And after 1 year of course or 2 year of course, these all symptoms became almost static. Even though he was taking medication, it was not having any response. So after 2 years, he was started on steroids. And last 5 years, he has got mycophenolate mofetil also. Even though he was getting all these treatment and he was compliant with this treatment, he was having no improvement in symptoms and no worsening of symptoms. Except for that thing is that wasting part and all and weakness of upper limb is started coming, but ocular symptoms was more or less static. He didn't had any further improvement with all these drugs. So because of this, he was having no improvement with drugs. Because of that part only, he came to us to see in our OPD. And personal history, he was a non-vegetarian with normal sleep and bowel and bladder habits. And there was no history of any similar illness in the family. So coming to summary, a 48-year-old male with no comorbidities presented with an insidious onset, indolent, 25-year history of chronic, asymmetric, initially fatigable, later fixed ptosis, binocular diplopia, and restriction of extraocular movements, and symmetric lower motor neuron weakness, as I am telling, because he had some atrophy, and wasting of bilateral proximal and distal upper limbs without lower limb involvement, and normal sensory cranial nerves, bowel and bladder involvement, and autonomic function with no significant response to immunotherapy. So, since patient had ocular symptoms like ptosis, double vision, and it was a lemon lesion pertaining that he had atrophy and he had weakness, and it was a pure motor weakness. Since the patient,
either mitochondrial cytopathy or central core myopathy.
sir,
Am I audible?
yes,
Yes,
sir. Hello.
Hello, am I audible?
Yes, sir, you're
Yes,
audible.
sir.
Yes, sir.
My diagnosis will be either a mitochondrial cytopathy or central core myopathy.
Yes,
Yes,
sir. We'll
sir.
be
Yes.
discussing the diagnosis. We'll come into that. And Vishnu, you should have written a binocular diplopia here, not a double vision, because now we're
Yes.
at the symptom analysis. So yes, it's a binocular diplopia will come. Okay.
Yes, sir.
Binocular
So
asymmetrical
since
diplopia.
yes, sir. So even though it started with initially he had fluctuating ptosis and that diurnal variation he was telling with the ocular symptoms and later progressing to pure motor element upper limb weakness. Because of this fluctuating nature and all, I want to keep localization of neuromuscular junction as first. And again, second part, because since it is a pure motor weakness and involving eyes and he had double vision, I had to put second as missing. Third, I kept anterior horn cell because later part he developed significant atrophy and weakness of upper limbs. Even though ptosis and double vision is not a part of anterior horn cell, still I had to keep as anterior horn cell as third part since he had significant atrophy and pure motor weakness. And when coming to the pathology, as we know, patient age of onset is almost 25 years. And here acetylcholine receptor antibody also came positive. So I want to keep autoimmune or acute pathology as first diagnosis. Followed that, since it is an young onset, we have to keep neurodegenerative or genetic as second differential. Coming to the diagnosis analysis. So actually he started with fluctuating ptosis and diplopia with fatigability and diurnal variation, and acetylcholine receptor antibody came strongly positive. With initially he had, according to him, he had significant response like mild improvement of ptosis with pyrostigmine. I want to keep first differential diagnosis acute generalized myasthenia gravis only. But point second is myasthenia gravis is, since it is an autoimmune disease, it should respond to immunotherapy. Initially, he had some pyrostigmine response, but later he didn't had any improvement with steroids or he didn't had any response with mycophenolate therapy. And over the years, it had extremely slow progression and some fixed weakness also. And one important point to notice is that he had significant atrophy, which is one little bit against neuromuscular junction pathology. Second, I want to keep is, since the age of onset was 25, it was little bit old for that congenital myopathy. Still, it started with an early ocular symptoms. And initially, he had mild response with pyrostigmine and no response to MMF. So I had to keep congenital myasthenic syndrome as one other differential. And point second is age of onset. Since it will be, it's like 25, a little bit old age for that congenital myasthenia, still it can happen. The acetylcholine receptor antibody came positive here. And here he didn't had any significant family history. And he had significant arm wasting also. Third differential diagnosis I want to give was mitochondrial myopathy. Since even though initially it was fluctuating in nature, this ptosis, later this ptosis became fixed actually. And he had proximal weakness with fixed external ophthalmoplegia. And some amount of fatigability was there. And this is there for almost 25 years. And he didn't had any response to myasthenia gravis therapy also. But as usually knows that mitochondrial can involve other areas also, like hearing, visual symptoms can be there. But he didn't had any symptoms, and here acetylcholine receptor antibody also came positive. So that was a little bit against mitochondrial myopathy. Fourth one I want to keep, it was oculopharyngeal muscular dystrophy as a muscle component. As we all know, it usually starts with that ocular features. So here it had ptosis and extraocular muscle weakness with proximal upper limb weakness, and over the years he had slow progression. But important point is now to note that age of onset it's 25. Actually, again it is here usually OPMD will start after 40 years only. So age of onset is definitely not fitting. And here he didn't have any bulbar involvement, and patient here complained of diplopia. Usually OPMD is a symmetric one. So patient, even though it is having some extraocular muscle involvement, they will not complain as such diplopia because it's a symmetrical involvement. But here patient had diplopia, so it is little bit against OPMD.
Here written no
Other-
diplopia, the actual should have been diplopia.
Yes, sir. Diplopia. It
No,
was
no, should not have been there. Yeah.
And the other differential I have to keep was congenital myopathy. So when I searched the research, like close one, what we can keep is congenital myopathy with adulthood onset, like autosomal dominant centronuclear myopathy, DNM2 related. Here point 4 was obviously progressive ptosis was there and ophthalmoplegia was there, and patient had, even though proximal and distal, symptoms started with the distal muscle involvement and then later becoming proximal. And points against was here usually this kind will be predominantly having lower limb. Here we had predominantly upper limb involvement, and they will rapidly progress to have some respiratory involvement and neck muscle weakness also. Here we didn't had any respiratory or muscle involvement, and there was no facial or bulbar weakness, and obviously acetylcholine receptor antibody was positive. Second, my congenital myopathy I have to give is MYH2 related myopathy. Here they will have CPO like presentation with ptosis, progressive ptosis and progressive ophthalmoplegia and proximal weakness. But one important feature against it is definitely patient had fatigability, initial fatigability and diurnal variation. That is against MYH2 related myopathy, and here there is not any bulbar involvement. And important point, MYH2 usually will be associated with contractures. Here we didn't had any joint contractures. So while coming to examination, what I wanted to see is basically is how is his built and nourishment. He was properly built and nourished person. His vitals were stable. Pulse rate was around 70 per minute, and BP was 134/76. Respiratory rate was 18 per minute, and saturation was normal, 98 on room air. And there was no any neurocutaneous markers. BMI was almost normal, 26 kg per meter square. And systemic examination here, particularly, I wanted to see, since we are considering myopathy, first I wanted to see respiratory examination, whether I have to see is whether he had any respiratory paradox or not, respiratory difficulty, breathing pattern, and chest expansion. And obviously, if it is myopathy related, some lung parenchymal abnormality can also happen. So obviously, I did a respiratory system examination, no CREPS was there. And CVS examination, I didn't find any cardiomegaly. Then abdominal examination, there were no any hepatosplenomegaly, or it was examination was normal. Now coming to nervous system examination. Sir, 1 second I will take. I have to put charger. So nervous system examination, higher mental examination was normal. MMSE was 30 out of 30. When coming to cranial nerve examination, this was his picture. This picture was taken according with his consent only. So visual acuity was normal, 6/6, and pupils, important to note, since it had ptosis, it was normal and it was reacting to light, and color vision was normal. And I wanted to look further specifically here because mitochondrial was one of our differential. to rule out retinitis pigmentosa, and I have dilated and seen it was not having anything. It was normal. Fundus was normal. And as you can see in this picture, that patient had significant frontalis overactivity and asymmetric ptosis with right more than left. And I will be showing the extraocular examination video. Actually, extraocular examination was movements was restricted in all gaze, and it was more in left than right. Ice patch what we have done, it was negative. Fifth nerve examination was normal, and this was the video. So as you can see, extraocular muscle, there was some asymmetry in extraocular muscle, as left was more involved than right. Right more, it was vertical than horizontal. Left, it was involved in all directions.
Patient didn't have any diplopia or double vision despite this asymmetry, right?
Yes, sir.
So there was no double vision despite so much asymmetry and despite
Asymmetry.
elevation of the right So
He
take
denied,
Yeah.
sir. Yes, sir. Other granular examination, seventh nerve examination was normal. As we had mitochondrial as our other differential, I wanted specifically to look for eighth nerve examination. So hearing loss obviously will come very important. Rinne's test was negative, positive, with Weber's was not lateralized. And since myasthenia, OPMD, everything can involve lower cranial, like lower bulbar muscles. So 9th and 10th nerve examination also will become significantly important. ULA was central and soft palate was moving symmetrically and equally in both sides, and gag was normal. And since he had prominent proximal muscle weakness, so examination of neck, like sternocleidomastoid, and examination of trapezius is also very much important. Both 11th nerve examination, trapezius and sternocleidomastoid power was normal. And since we had other differential of anterior horn cell, 12th nerve examination also is very much important. So I looked for atrophy. Any fasciculations were there or not, or wasting of time? It was not there. Everything was normal. When coming to the bulk, I have one picture. Actually, he was having symmetrical atrophy of muscles. As you can see, he was having proximal and forearm. Forearm, I have separate photos. So proximal, as you can see here, he was having atrophy of deltoid, biceps, triceps, supraspinatus, and mildly infraspinatus. And this here you can see forearm. Forearm was having significant atrophy, more on the medial aspect than lateral aspect, and there were no any lumpy bumpy appearance. One another point to note is that he was having little bit a lordotic posture and some mild baldness and protuberant abdomen in this picture, and you can obviously see he had that atrophy of biceps and triceps, and mild like deltoid also posterior segment, and supraspinatus atrophy also is visible here. When coming to tone and power, he had hypotonia in upper limb, especially on elbow movements, and normal in lower limbs. Power examination, it was predominantly more distal weakness than upper weakness. The shoulder was almost 4+/5, symmetrically both, and elbow was 4/5 with the wrist at 4/5. Even though in the previous picture, small muscle of hand, bulk seems to be normal, but he had weakness of both small muscles in both right and left side, and hand grip was almost 30% only. But lower limbs examination was like power was almost full with hip, knee, and ankle. Everywhere it was 5/5. And when coming to deep tendon reflexes, everything was normal. And bilateral plantar was flexor. Other superficial reflexes was normal. Here I specifically wanted to examine Beaver's sign because he had some protuberant abdomen and myopathy features. So to rule out abdominal muscle weakness, but Beaver's was negative. No signs of incoordination, and sensory examination again, it was very important because since it was a pure motor, so rule out sensory is very much important. Cranium and spine examination, even though he had some lordotic posture, it was fine. Examination was fine, and gait was normal.
So Vishnu, you can get the muscle examination normal in such a case, especially when you're getting a fatigable weakness. So what was your forearm abrasion testing and other fatigue test showed?
Actually, fatigue test was when we done ptosis. Actually, when we are done ptosis, 2 minutes examination.
Because that is the basis of NMJ junction disorder. That if you do a stat examination, that power can be normal. That's the problem. Okay.
Yes, sir.
So did you do the forearm abduction test and the squat test or not?
Yes, sir. What
Lower
all
limb complaints
testified?
were not there, but like forearm ablation test at least.
Yes, sir.
So was it
Actually,
positive or negative?
no, sir. It was negative. Thing is like when he came also he didn't he when he came to us when we examined his also the proximal weakness he never complained. When we examined only he had that complaint properly. Main
So
was he was having significant
he had
atrophy.
forearm ablation test was adequate. It was
To,
quite good.
yes, sir.
And
Yes, sir.
second thing, did you observe that when he sleeps and gets up, did his ptosis and eye movements improve or not? These two questions.
No, sir. Actually, when
So
we
currently he
examined,
was
he
not having
didn't had any.
fatigability, so whatever it is fixed, and there was no fatigability in currently as of
When
now.
we current situation when we
Right.
examined, he didn't had, sir.
Yeah. So I stopped you because it's a common mistake if we get such a case in exams or somewhere. It's very important that in addition to nutrition, tone, power, and abdominal movements, coordination, these are the five headings of muscle power. We should add special tests in which we should see the fatigue and fatigability and this test. Okay,
Okay,
fine.
sir.
Was an ice pack test done?
It
Yeah,
was
ice
done,
pack
sir.
was
It was
negative. That
done,
was
ma'am. It
put
was
in the
negative.
cranial nerves. Yeah.
Okay.
So coming to summary, a 48-year-old male with no comorbidities, presented with an insidious onset, indolent 25-year history of chronic, asymmetric, initially fatigable, with some response to treatment initially, later fixed ptosis, binocular diplopia, and restriction of extraocular movements, and symmetric lower motor neuron weakness and wasting of bilateral proximal and distal upper limbs without lower limb involvement, normal sensory, cranial nerves, bowel bladder and autonomic functions with no significant response to immunotherapy. So again, hello.
Vishnu, please
Again,
continue.
when after my examination also, again my differential diagnosis first differential will be acquired generalized myasthenia gravis only because of the significant history and examination finding we got. Even though we didn't find any examination any fatigue while we are examination, as his history also he told it has become almost static. Still, I like to keep acquired generalized myasthenia gravis as differential diagnosis here because of initial significant fluctuating doses, fatigability, then acetylcholine receptor antibody positive and initial response to pyrostigmine. Against was again, he didn't have any significant response to steroids and extremely slow progression with fixed weakness and significant atrophy. Second, I like to keep is congenital myasthenia syndrome. Obviously, it is possible here. Only thing is that age of onset was later, like it is a little bit later onset, and acetylcholine receptor antibody was significantly positive here, and he didn't had any positive family history. Third one I have to keep is again
Yeah, I just I
mitochondrial
want to
myopathy.
add something here. So age is not a very strong criteria, but yes, it should be usually early. And one more point is when we are seeing these points for, you should see the demography also. So this type of presentation happens in which CMS, which type?
Ocular, predominantly ocular and
Which type? Which mutation?
acetylcholine receptor
No, so it's a epsilon type. Okay.
epsilon.
So
Okay.
epsilon, yeah. So Cherny. So what happens is that is the most common also in India. So age is not something which will be can exclude, but still it can appear late also. But 25 years is a bit more late, and then positivity of the CMS. So CMS will also be a strong contender here.
Yes, sir. And
Fine, continue.
third differential is mitochondrial myopathy. Again, he had significant that later part fixed ptosis with proximal weakness and fixed external ophthalmoplegia with long duration and poor response to myasthenia gravis therapy. But he had again acetylcholine receptor antibody positive and other system involvement also. Ocular, I will keep last. Oculopharyngeal muscular dystrophy. Since age of onset was not fitting, and he had initially diplopia history, even though he had ptosis and proximal muscle weakness. So we wanted to go for other investigations. So here we have done routine blood investigation. One point I want to note stressfully note that since myopathy was one of our concern, AST, LT, liver enzyme profile was very much important and it was normal. And another great important point to note is thyroid function test. Obviously, one great it can per se can cause myopathy. So thyroid function test was normal, and renal RFT was also normal. CPK was another important test. It was also normal. And we have repeated acetylcholine receptor antibody again. repeated value also came positive. Initially it was 2.5, again it became 2.97. And since it was a mitochondrial, we have done ABG lactate levels, it was normal. And since we have to rule out other involvement also, pure tone audiometry for hearing loss was done, it was normal. 2D echo to rule out cardiomyopathy, and it was also normally, it didn't had. And we have done rhythm ECG also to rule out any arrhythmia, and it was also normal. Since acetylcholine receptor antibody was positive, thymoma was one other correlation. So we have done contrast enhanced CT to look for thymoma, and it was negative for thymoma.
So
Then we
just a point I
proceeded with
want to make here, Vishnu, previous slide. I just want to make a slide here that you should not forget the importance and the things you are doing. See the thyroid, other than the routine investigations, the thyroid function test has been done. There are differences which involve the cardiac abnormalities. So cardiac workup is important. ACRAB has been repeated, and more important thing is when you're suspecting neuromusculation, contrast and then CT should be done. Sometimes these things is missed, so it's important to get contrast and then CT just in all the cases, which has been done here. Fine, continue.
So we went ahead with the electrophysiological examination. Nerve conduction study was normal. Needle in EMG was done. It was having no spontaneous activity and normal movements with no evidence of myopathy. And that EMG, this was EMG of deltoid muscle. Actually, it was having normal amplitude movements and normal recruitment also. And since myasthenia gravis was differential, RNST we have done, but we didn't get any significant response in 3 Hz RNST in ocular, trapezius, and APB muscles for him.
One more important thing there is that whenever you tell the RNST, it's not adequate to say positive or negative. You should always tell which muscles RNST you are talking about and how much decrement. So here it has been told that ocular, trapezius, and APB muscles were done. It was negative, right? Fine.
Yes, sir. And since mitochondrial was our other differential, so we want to do MRI brain and see for any brain changes related to mitochondria. But actually, MRI brain, this is a MRI brain T2 flare axial section. So this picture actually was normal, except one finding I will tell. I have a separate photo for that. Actually, extraocular muscles compared to other usual muscles, it was it was seemed to be atrophied. I have a separate photo for that. I will show that.
This is MRI brain plus orbit, right? So in such cases, you should write clearly. It's a common mistake when you write MRI brain only. You should clearly write what sequence and what indication, what organs are needed. Okay, so this is MRI brain plus orbit. Only then you will get such detailed information. Otherwise, the gap they take of 5 mm will just clean off all your orbit. Orbit is a small portion. Okay. So here it was MRI brain plus orbit.
Orbit.
Yeah.
So it was having generalized extraocular muscle atrophy. This was our picture, our patient picture. It was showing extraocular muscle atrophy, and this is one normal picture showing extraocular muscle. So you can see actually left side extraocular. Here also he had more symptoms on the left side. So left-sided extraocular muscle seems to be significantly atrophied than the normal picture, what you are visible. And since importantly, we have to notice that since we had a diagnostic dilemma here the patient had myasthenia-like features, but he didn't have any significant improvement. So we had one differential of congenital myasthenic syndrome and mitochondrial as one differential. So here it was very important to do whole exome sequencing with mitochondrial genome sequencing for evaluation. So we have done whole exome sequencing with mitochondrial genome sequencing. Actually, it is a bit expensive, but we.
See, the thing is, whenever the genetic case we are suspecting, we always have a tendency to send whole exome sequencing indiscriminately, thinking that it covers everything. There are certain disorders which are not covered. One is obviously if the patient you're suspecting a genetic disorder, patient doesn't have a genetic disorder, then the whole exome sequencing will not show up anything. But other than that, if the pathology being concerned, then mitochondrial repeat disorders and the karyotyping disorders, like suppose they are talking about Down syndrome and all those things, there are a few things which will not appear on the VES. So mitochondrial is one such thing. So what was your approach while sending the genetic testing in this case? How did you send? What did you discuss with the patient and the lab?
Actually, thing is, initially we were thinking we will send whole exome sequencing, because whole exome sequencing in the lab it is almost like 8,000, and mitochondrial separate if you are doing it will again cost 4,000. So patient was not much that much affordable for this. Then we talked to the lab that we thing is like we are suspecting both. We had strong suspicion of the both, so we had talked to the lab like whether we can do in a low rate. Actually, they agreed, and we got in 8,000 rupees itself both tests done for him.
Yes, so
Uh,
sometimes the timely discussion with the lab and open communication with the pathologist is very important and it benefits doctors and patients both. So here you can save a few bucks also and you could get the diagnosis. But surprisingly, here the West is showing some changes, which is not expected in case of mitochondrial, right?
Yes, actually here West came positive for MGME1 mutation. Actually, it is an heterozygous mutation what we got, and it is having autosomal recessive, and it is a mitochondrial pathology, as we all know. But point to be noted is that we got it as a variant of uncertain insignificance only. So we can't take it as a definitive evidence for mitochondrial in this. So after this, we had to proceed with either Sanger sequencing of parents for this patient, or we have to examine parents also. So we called basically we called his parents, both father and mother. Actually, they didn't had any symptoms. We examined for them also. They didn't had any proper findings also. So we proceeded with Sanger sequencing in them. Actually, Sanger sequencing in father was negative, but Sanger sequencing in mother turned out to be positive for the same gene. It was MGME1 mutation, and again heterozygous it was, and autosomal recessive. So it was fitting to mitochondrial DNA depletion syndrome.
So there
But
is a
problem
very
here is,
important message in this slide that some many times when you get some like the BUS in the patient, then you may have to take up the normal relative, especially the mother, father, and do the sequencings and testing. Only then it will give a further indication and insight in the diagnosis. So fortunately, the
yes, sir.
patient could afford
One
this and this test could be done in the parents.
Yes, sir. But one important
Yes,
point
sir.
here to be noted is that actually mitochondrial is having maternal inheritance. And here this MGME1 mutation is autosomal recessive and it is heterozygous. Thing is like to get affected, both allele has to get affected. Here, since mother was not affected, like it was heterozygous, she was a carrier and she was expected to be asymptomatic. So this analysis also, we can't tell, even though Sanger sequencing came MGME1 positive, it does not confirm that it is a mitochondrial thing. It still persists like it is a variant of uncertain significance only. Even though
Yes,
it came positive,
the test should be taken as confirmed only when the clear test clears as pathogenic.
pathogenic,
VUS needs a
and
very careful
yes,
interpretation. It is difficult to interpret. Yes, right.
yes, sir. So we had to confirm diagnosis. So we asked the patient whether we can proceed for biopsy, whether he is affordable or not. So initially he was not accepting, but later he understood what we wanted to do. So he accepted, and we have done muscle biopsy. So this was the muscle biopsy picture. Actually, we had to look for we are thinking mitochondrial pathology, so we were looking for red rag fibers. So two staining was done. It was Gomori trichome staining for red rag fibers, as you can see in the right side, and Cox staining for again muscle pathology. Here Cox was negative, and Gomori trichome was positive for red rag fibers. One point to note is that red rag fibers can be seen in normal persons also, especially in old age. Around 2% of the persons can be these red rag fibers can be seen. But there we have to think is like this COX also can be getting positive. So here COX is negative, and red rag fibers for Gomori trichome came positive. So almost we had clinically we suspected some mitochondrial pathology. We got, even though it was VUS, we got MGME mutation, which was correlating with our mitochondrial pathology. And again, when we are done muscle biopsy, it came positive for red rag fibers. So obviously, we have to consider mitochondrial pathology here. This biopsy again, overall, if we are correlating, it was a good part we have done muscle biopsy here. So because we are strongly suspecting mitochondrial pathology, we tapered and stopped this prednisolone and pyridostigmine. and we discontinued his microcognitive morphical also. So after 3 months, like regularly 1 month he was following. After 3 months, we evaluated him further. We he didn't had any worsening and he didn't had any further progression of illness. So overall, we stepped and stopped these drugs. And initially, we were planning to give mitochondrial cocktail. So problem was he was initially not affordable, and we wanted to see whether this any stopping of these drugs will cause any worsening or not. But after 3 months also, he was almost static. So we were sure that it is not going to worsen. So we tapered and stopped, and we planned to give mitochondrial cocktail in his next visit. So from this discussion part, I invite Dr. Sharanya to present from her part.
So Dr. Saranya is assistant professor at our department, and I welcome Dr. Saranya. A very good morning. Thank you for such a beautiful presentation.
Thank you, sir.
And please give us insight in this complicated case.
Yes.
So where everything is open, but still diagnostic dilemma is there.
This patient had a mitochondrial mutation, which was an NGME1 mutation, and he had a strong history also suggesting that it is not like it's a progressive myopathy, even though acetylcholine receptor antibody was positive. He had a strong genotype-phenotype correlation, and also muscle biopsy showed presence of red ragged fibers and Cox negative fibers. So this diagnosis is almost consistent with a mitochondrial myopathy. And coming to the discussion, MGME1 gene encodes mitochondrial genome maintenance exonuclease 1 enzyme, and this is involved in mitochondrial DNA replication and repair. Any mutations in this genes is associated with mitochondrial DNA maintenance disorders. They are referred to as mitochondrial DNA depletion syndromes, usually presenting in childhood with severe hepatocerebral form and severe myopathy-like presentation. Usually in adults, the presentation has been reported in various case reports as progressive external ophthalmoplegia, diplopia, proximal myopathy, with adult onset and very slow progression. There have been 2 or 3 case reports where this gene mutation has also been associated with cerebellar ataxia and cardiomyopathy. Vishnu, please change the slides for me. Yes. So these are this is the review of literature of previously reported MGME1 variants. So initially reported by Kornblum et al. In 2013, he had reported 2 patients who had similar presentation as our patient, except that this patient also had respiratory failure and multisystemic mitochondrial manifestations. There have been other reports also with similar presentations with adult onset PEO-like presentation, and there have been cases of early onset cerebellar ataxia and cardiomyopathy also, which has been reported in 2026. Continue. So coming to this patient, so this patient had acetylcholine receptor antibody positive. So how to fit in this acetylcholine antibody positivity with our diagnosis of mitochondrial myopathy? So previously there have been many cases with false positive acetylcholine receptor antibody positivity. Our patient, we did binding antibodies to acetylcholine receptor, and it was done by ELISA test. So like there is difference in sensitivity and specificity of various methods or various assays which are used to detect this acetylcholine receptor antibody. So we can have false positive acetylcholine receptor antibody in various situations. Like I have mentioned here, we can, like there was case report by Sundar et al. Where AChR antibody was falsely positive in patients with snake bite after anti-snake venom exposure. There have been false positive AChR receptor antibodies in congenital myasthenic syndrome, COLQ mutation, GBS, and motor neuron disease. Next. So the various antibody assays, the gold standard is usually radioimmunoprecipitation assay, which we usually widely use with a very good sensitivity of 85% and
So, Saranya, just a minute. Alan sir. Lakshmi sir. Okay, not
here.
I think
I'm here.
I think this was what we were talking about. I think this slide is the one
Yeah.
you were talking about.
Yeah, I was talking about.
So it is very important nowadays to be aware of this, so many tests and everything going on. We cannot just go by the positive, negative, or just by the levels? What type of test we need to do? So we will have later discussion on this. Yeah.
Yes.
Yeah. Previously in mitochondrial myopathies, I could not get SHR antibody positive, be it false positive or whatever. But here in our patient, we have repeated the SHR antibody twice, and both the times it was significantly positive, but both tests were ELISA. So as you can see, ELISA test has a sensitivity of 70 to 75% and a specificity of more than 90%. And maybe we can confirm in this patient by doing a fixed cell-based assay. So next. So the take-home points from our case would be a long-standing myasthenic symptoms like fixed long-standing symptoms with ophthalmoplegia, muscle wasting, poor immunotherapy response. It should prompt reconsideration of alternate diagnosis, and we should evaluate for other disorders like mitochondrial myopathy. ACHR positivity does not exclude alternative diagnosis, especially in atypical clinical contexts. Usually, this false positives usually fall less than 1 nanomole per liter range. However, our patient, we still believe it was false positive. It was more than 2 nanomole per liter range. So we have to confirm the diagnosis again by cell-based assay, and genetic testing will also obviously help differentiate the true myasthenia from the mimics. And genetic findings must be interpreted with caution in the light of inheritance patterns and clinical correlation, especially in mitochondrial maintenance disorders. And so a proper diagnosis would avoid unnecessary immunosuppression or thymectomy in atypical cases, which present with myasthenia-like symptoms. That's all. Thank you.
With the permission of the chair, I just wanted to add a couple of things.
Sure, sir.
Regarding the assay, should know what is called what is prozone phenomenon? Prozone phenomenon. Prozone phenomenon is when the acetylcholine receptor antibodies in a very high titer, the test will turn out to be negative because there will be sufficient, they don't have space for forming immune complexes during the assay. So in spite of a very high acetylcholine receptor antibodies, it can come as negative. It's called false negative because of the prozone. So this is one thing which while you are interpreting these results, you should know. Second thing is, we are now, after the advent of LRP4, Agrin, and MuSK, all the four, the phenotypes are completely different. We have a large, almost more than about 20-30 cases. They are very close mimics of the Agrin, and LRP4 are close mimics of ALS, including fasciculations in the tongue and generalized fasciculations and typical ALS features, but turned out to be Agrin and LRP4. And we have tried immunotherapy on such patients. At least a subset of patients which show remarkable improvement were on Rylstube for fairly a long period of time where it has improved. And thanks for a wonderful case and a wonderful discussion. In fact, I was requesting, I'll talk to you after the completion of the meeting. This is a wonderful thing. This should be taken to the national level. Thank you. Thanks for Professor.
Sir, thank you for your valuable insights. Thank you, sir.
Excellent, President Vishnu. My special congratulations. Very well discussed, and Saranya, both of you did a wonderful job. Under the guidance of Vaibhav, I'm really happy. On a Sunday, I felt this 1 hour is very, very worth spending. Thank you. Learned a lot of things. Thank you from all of you. Sir, with VN sir, we'll go. Shall we move on to the second case, sir?
Yeah, Natarajan sir was right, sir. At the initially said mitochondrial. Just want to add that.
Sir is the Bhishma Pitar of neurology in India.
So we can, anyone has any question can ask in the chat or somewhere or
chat. There is nothing. The chat is already the.
I answered one question was asked, but that was already in the.
That was already answered.
I already answered it. Yeah.
Yes, we move on to the second case.
Sir, how do you explain the lower limb weakness and
lower limb was normal?
Proximal muscle weakness and wasting was seen?
I think
weakness was in the upper limbs, sir. The lower limbs were normal for this patient.
No, I'm asking about upper limbs only.
Yes, sir. He had proximal upper limb and distal upper limb weakness with wasting, sir.
How do you explain that?
Long-standing myopathy.
Is it associated myopathy or is it associated anti-tonsil? Because EMG was normal.
Yeah, EMG was normal, sir.
Normal.
EMG did not even show a myopathic pattern to our surprise.
Myopathic.
Yeah.
There's no
CPK
myopathy,
was
no
also normal, sir.
neuropathy.
CPK was
No,
also
no.
normal.
CPK normal.
Actually,
CPK was also normal. VN was
mitochondrial myopathies, lot of times the EMG can be normal because it is essentially an intracellular organelle thing. So it is. I have seen quite a lot of occasions where the patient had definite proximal myopathy, where the EMG didn't show myopathic pattern. So it is essentially the mitochondrial myopathy where the EMGs can. I have seen, at least I don't know, Professor VN should be able to tell, sir. I have seen quite a few cases where the EMG was normal in spite of the patient having ragged red fibers, all classical mitochondrial myopathy where the EMG was normal, sir. CPK was also normal.
Now, how do you explain that then? Now, there should be some
We don't know
explanation.
because it is essentially it is more similar to an energy failure in the muscle rather than the. So because a mitochondrial thing is an energy thing and it is more of an energy failure in the muscle that results in the muscle atrophy, not the muscle contractile mechanism is not the involved, sir.
Again, no other system is involved.
Here, we screened, sir. We couldn't find any other system involvement. Heart, ear, auditory system, everything was within normal.
Fundus also.
Fundus also was normal.
So it's a pure specific muscular mitochondria.
Yes.
Mitochondrial. This
But
is something which we have
proven
never
by
seen.
biopsy, because biopsy they have not given the percentage of red ragged fibers. So it should be more than 2, but the report didn't say so. Okay, how much percent? Because it's a 48 years old. It should be clear cut more than 2% only. Then you will say RRF. But the RRF
And
percentage
he has
was
gone.
not
It
given.
has gone for nearly 25 years.
Yes, sir. 25 years.
Onset also at 25 years age and 25 years of progression also.
Purely specific muscular mitochondrial disorder.
Looks like that, sir. Because
That is-
alternative we are unable to think of. Now we have stopped all the things. 3 months have already passed. We'll just see what happens after in around 6 months. We hope that it doesn't worsen.
The mitochondrial cocktail would definitely help.
Okay.
Yes, we will start that. And one more important thing in this, that what she's saying, one of the case reports showed cardiomyopathy also. So in this case, we have to carefully screen. Cardiac screening has to be done every yearly or once in 2 years. So
So
that will
similar
also be important.
muscle-only presentations have been reported with other mitochondrial mutations like PEO, TWNK, and all. It can isolate itself to the neuromuscular muscular manifestations without actually involving other systems, sir. Limited muscular involvement has been reported with other mutations also. This is one new mutation, MGME1. Previously from India, I haven't got any other reports of this mutation, sir. It was reported from Iran and all, this is there, but from India, this may be probably the first.
Mother's mitochondrial study was positive. In a sense, it was like a type. And what about the previous generation in the history wise for the mother?
History wise, we couldn't get, sir, anything, any contributory history we couldn't get, sir. 3 generations we had inquired. We were not able to get any positive history in any of the members.
Oh. Yeah, this is something which we have never seen before. Yeah.
Yes, a family history is always, we can never 100% rely on the family history. It can always be missed.
Thank you, sir. Can we move to the second
So we
case?
finished our first case in 50 minutes. That's good. We saved 10 minutes. So next case will be presented by Dr. Manoj, right? Yeah. Yes.
Very good afternoon, everyone. To respected Ellen sir and our faculty, Dr. Vaibhav sir and Saranya ma'am. Hello.
Yes, please proceed.
Yes, am I audible, sir?
Yes, you are audible. Yes.
Yes, sir. And starting with the case, our case is a treatable shadow behind a degenerative mask, a diagnostic challenge. Myself, M. Manoj, senior resident in Department of Neurology in JIPMER. Patient details: our patient is a 60-year-old gentleman. He's a fisherman from Kadalur. He's a right-hand individual with no formal education. Informant is himself and his wife. And he came with the chief complaints. He came with the chief complaints of gait disturbances and recurrent falls for 1.5 years, slowness for 1.5 years, limb tremors for 1.5 years, speech disturbances for 8 months, memory disturbances for 4 months, behavioral abnormalities for 4 months, and giddiness for 4 months. History of presenting illness: 1.5 years ago, he attempted to. Our patient is a fisherman. He goes to offshore for fishing and all. He goes for a weeks together along with his friends and other boats. One day he attempted to jump from one boat to another boat. That he used to do very often when he is in the sea. And one day he suddenly slipped and fell down between the boat. That was the first instance of him to note something abnormal with him. And in another 2 weeks, he had instability and fell forward when lifting the nets on the shore. However, there is no history of loss of consciousness or involuntary movements. After falling down, he was unable to get up on his own, and nearby people came in to pick him up. And 2 months later, he attempted to get up from the chair at home. He became unstable and swayed and fell forward en bloc. Sustained abrasion over the face, and he took treatment in the local hospital. And within the same month, on another day, attempted to get up from the bed, fell en bloc backwards. Multiple such falls en bloc, predominantly towards the backwards more than the forward. And all these falls were intermittent. Means that are not there all the time. And during the falls, there is no giddiness, no loss of consciousness, no sweating or palpitations, or no major head injury. And within 2 months, he started walking slowly and carefully, keeping his legs wide apart with caution, in a fear of falling. And slowness of activities, and he noticed difficulty in turning over the bed and getting up from the bed. Wife noticed whatever he is doing very slowly. He is taking more time to getting up from the bed. He is taking more time for the bathing. He's taking more to finish eating. He is taking more time to walk in and around the home. Within 2 months after the onset of the illness, patient in a fear of falls, he stopped working because he is a 60-year-old and his family is earning decently, and he stopped working. And when he's staying in the home for most of the time, wife noticed that all the activities he's doing in the home were very slow. And he insidiously noticed a difficulty in using the Indian toilet. And he felt both the loneliness were tight and complained the same to the wife and his son. And ultimately, they had to change to the Western toilet because of this issue. And he had difficulty in bathing. He was unable to clean the back also. And he noticed both upper limbs were tight. And for the same reason of both upper limb and lower limb tightness, he stopped squatting on the floor and eat. He started using the chair to eat. And around the same time, he noticed the tremulousness of both the limbs. He noticed mild shakiness of both the hands when holding the objects, like for example, glass of water or a cup of tea. However, there is no smearing of mouth, no spillage of contents. The tremulousness was not severe enough to cause like smearing of mouth or spillage of content. But however, there is mild shakiness of the objects when he is particularly holding hands when particularly holding an object. There is no shaking at rest or sleep. There is no history of random flowing movements or violent flinging movements, jerky movements, or involuntary tonic-clonic movements. He also has speech disturbances for the past 8 months. Speech disturbance in form of slurring of speech. He was unable to spell the words clearly. He is speaking slowly, unable to talk loudly like before. That was the only thing they noticed. Wife complains that he is speaking slowly, unable to talk loudly like before. However, he responds appropriately and he is comprehensible to others. Whatever he is saying, if it is audible to them, if they are nearby to him, they will understand, and whatever they ask him, he will respond appropriately. And there is no history of nasal regurgitation or no dysphagia, no nasal twang of speech, and no choking sensation while eating. He also has episodic memory disturbances for the past 4 months. Like frequently, he forgets to take the medication for the past 4 months. Previously, he used to take medication for his diabetic and hypertensive medication. He used to take it, and for the past 4 months, he is forgetting to take the medication. Yet few times he asked the food again, and like after having the breakfast also at around 10 or 10:30 a.m. He used to ask, why didn't you? He used to ask his wife that why didn't you keep me the breakfast? When the wife tells him that you already had breakfast, then he will accept. Yes, I had it. He will agree for that. He recalls with the clue, and there is no other memory disturbances, and he is able to remember all the old relations, festivals, and recognize faces and family members. Also, there is no history of irrelevant talk. And behavioral disturbances for 4 months are there in the
Manoj,
form of sir.
Dr. Manoj.
Yes, sir.
So when you use the terms now, you have to be very careful. You use the word episodic right now.
Yes, sir.
So when do you use the word episodic? When you use the word episodic, it means that abrupt onset, abrupt offset. Then it
Yes, sir.
lasts for few times, a few minutes, it lasts and then it goes off. I don't think that is what is happening here. Okay.
Means that he is
So
not. Yes, sir. He is not
just listen to me.
forgetting like to
Manoj,
take medication every time.
Manoj, just listen to me. See, in the memory disturbance also, it will not happen always and every time. But term episodic is a problem. Episodic, paroxysms, these terms are problem per se. So these are
Yes.
just memory disturbances which happened over the duration of time. Sometime he remembers, sometime he forwards. When you
Yes, sir.
say an episode, it just lasts for 5-10 minutes and it disappears then completely.
Okay, sir.
It is not like that. Okay. So
Okay, sir.
as a student, I am telling you, whenever the students are using these terms in exams and everywhere, and even while interpreting more than exam,
Yes.
you have to be very careful. Okay.
Yes, sir.
So patient has memory disturbances in which recall with cue is the present. That is the thing that is being conveyed here, what I
Yes, sir.
got from the interpretation.
He
Okay.
has recalls with clues,
Fine.
sir, and
Yeah.
it is more of a retrieval defect than the storage defect. That's what
Yes.
I just
So
wanted
this
to
continue
add.
with the behavior abnormality. Yes.
Yes, sir. And patient has the behavioral abnormalities for the past 4 months, sir. In the form of he's staying idle. He's disinterested in the daily activities. He used to be very active previously. At his 58, 59 years old age also, he used to go for the onshore, offshore shifting and all he used to do. But for the past 4 months, he's staying idle and disinterested in all the daily activities. He noticed, the wife noticed he's having difficulty in counting money also. He has issues with the finances. And however, there is no other behavioral abnormalities or no sleep abnormalities also there in this patient. And he also noticed giddiness for the past 4 months.
One more
Particularly from,
thing, difficulty in counting money can go in acalculia also. Okay.
yes, sir.
So this may not be a purely a behavior abnormality. So you have to, when you examine the case, you have to be very careful about the patient has a dyscalculia or not,
Yes,
which
sir.
indicates a widespread and a different organ
Different
other than frontal lobe also is
lobe.
involved. It shows. Okay.
Yes, sir.
Fine.
And he also has giddiness for the past 4 months, particularly when he get up from the sitting position, getting up from the supine position from the early morning, particularly in the early mornings. When he is getting up from the sleep, when he woke up and get up from the sleep, he is having the giddiness. And also it is there from the sitting to standing also. This was associated with the lightheadedness and the sweating. And occasional issue of palpitations also there. There is no chest pain. He gets better after lying down for half an hour. There is no loss of consciousness or no major fall due to this.
See, so just a minute here. So it is very
Yes,
important when you say giddiness in any case. Giddiness must always have a syndromic differential. So the different causes, the different things which patient and interpret complaint as giddiness are. One is vertigo, one is syncope, one is syncope, pre-syncope,
please info.
one is postural instability, one is ataxia, and one is psychogenic. These are the 5 important I am telling you. In
Yes,
this, patient is already having a postural instability where his patient is
yes,
falling unblocked and all those things. So that can also be present as giddiness. But this giddiness looks like different because he specifically complains of sweating and lightheadedness.
yes, sir. That was there
Okay.
for the past 4
So
months.
it looks like going into the presyncope and syncopal area. So it's giddiness is a very good example how to interpret the complaints.
Yes, sir.
So going towards the syndrome is very important.
Yes, sir. And no history of chronic fever or headache or vomiting or altered sensory in the past. No loss of appetite and weight. No history of chronic diarrhea or abdominal pain. And coming for the past history, patient is he is a person living with HIV and AIDS, diagnosed 25 years ago on TLD regimen. It is tenofovir, lamivudine, dolutegravir. He is taking regularly. He is taking regular medication for the past 25 years. He's on regular follow-up also, and he's also diabetes and he's also known diabetic and hypertensive for the past 5 years. And this also he's on the regular medication. And there is no history of chronic kidney disease, liver disease, or COPD, asthma, stroke, epilepsy, or thyroid disorder in the past. And no history of PTB or any contact with the tuberculosis in the family. And the family history is not significant. No other family members have the similar illness or any chronic neurological disorder. Personal history, he has a normal appetite and normal sleep. There is an increased frequency of micturition with an there is only the increased frequency of micturition. There is no dysuria. There is no urgency. There is no incomplete voiding. Otherwise, there are no otherwise normal bowel habits are there. And he's a chronic alcohol consumer. He consumes 3 to 4 days per week, 1/4 per sitting. And he stopped 1.5 years ago after the current illness. After he stopped going outside, 2 months into the starting of the illness, he stopped doing alcohol consumption. He's a non-smoker. There is a history of high-risk sexual promiscuity for him.
So I just want to confirm one point here from Manoj in the previous slide. I hope that now you have clearly taken a detailed history about the sleep, because very unusual to find sleep completely normal in such a case. So in the case of history of sleep, you have to ask the sleep latency, duration of sleep, excessive daytime sleepiness, any enacting of dreams in the sleep, which we call a RBD or progression. So all these are negative in this case, right? You are taken in detail.
Yes, sir. Negative in this
Okay, and
case.
no snoring and no these things.
No
All
snoring,
these
sir.
things you have inquired and they were negative, right?
They were negative, sir.
Fine.
And coming to the summary, our patient is a 60-year-old gentleman who is a known PLHA on ART TLD regimen for the past 25 years and a chronic alcoholic and also a diabetic and hypertensive, presented with 1.5 year history of chronic insidious onset and progressive symmetrical appendicular and axial rigidity, bradykinesia, postural instability with recurrent en-bloc falls, predominantly backwards with hypokinetic dysarthria, with memory impairment, behavioral disturbances in form of apathy, and possible autonomic disturbances in form of postural giddiness, without involvement of other human cranial nerve, sensory and cerebral, and currently dependent on the activities of daily living, predominantly for the ambulation. And clinical feature, symptom, and its localization. He has a global slowness and trunk and limb tightness. Global slowness correspond to bradykinesia. Trunk and limb tightness correspond to rigidity, that is axial and appendicular rigidity is there. These 3 complaints will localize to the basal ganglia and their connections, extrapyramidal system. And he has an early recurrent falls. This symptom correspond to postural instability. Postural instability can be due to an autonomic thing, or most likely in this patient might be having a localization to the midbrain tegmentum and pedunculopontine nucleus because of the postural instability. He has an occasional forgetfulness, correspond to memory impairment, medial temporal lobe and its connections. He has an apathy, and that is a behavioral abnormality.
Yeah.
Localization
Dr.
to the
Manoj.
anterior sir.
Yeah, I got one comment and I was wrong in that case. You were right. That episodic memory loss means that you meant episodic type of memory loss, right?
Yes, sir.
Yes, I misinterpreted it like episodic memory loss. So it was my mistake. So that is the correct usage. If you are using the episodic type of memory loss, it is good. Fine.
Yes, sir.
Please continue.
And yes, sir. He has a memory impairment and correspond to medial temporal lobe and its connections. He has an apathy that correspond to behavioral abnormality and localization to the anterior cingulate, that is in the frontal lobe. And he has a giddiness, and this is a new onset giddiness for the past 4 months, correspond to the query possible postural giddiness that may be due to the autonomic disturbances. He has an increased frequency of micturition is there with no other urinary disturbances that correspond to the urinary disturbance. However, it is most likely it must be due to diabetes related, or we want to rule out autonomic disturbances in the background of him having the giddiness also, postural giddiness. And etiology, what we can consider is it is a rapidly progressive atypical Parkinson syndrome. In a PLHA patient, first we would like to rule out infection. He is a PLHA for the past 25 years. We want to rule out chronic infections due to HIV per se or any other opportunistic infections related to HIV. And second, we go to neurodegenerative disorders like PSP and MSA and NPH. And third, we would like to keep vascular Parkinson disease because of the patient risk factors and age. And fourth, we want to keep autoimmune, and fifth, paraneoplastic also, because we want to keep, it is a 1.5 year history. It is not so much rapidly progressive. It's not months to weeks, weeks to months history. It is a 1.5 year history. We would like to keep autoimmune and paraneoplastic little bit later to the vascular Parkinson's, and we want to keep the metabolic also because he's taking multiple drugs related to the HIV, and we would like to see the all the drugs related to them also. We want to see. And
this is a very good clinical practice. metabolic you should always keep when you're interpreting a Parkinsonism, even if it is chronic. Okay. So drug related things you have to carefully observe. If you find new drug which you are not aware of, please go back and read the literature of the drug, whether it can cause the Parkinsonism or not.
Yes.
So please continue this practice and others should acquire if they are not already doing it here.
Yes. Basically, this patient has a clinical syndrome of rapidly progressive atypical Parkinson syndrome in a PLHA patient, and these are our in a priority order. First, we would like to consider HIV per se and HIV associated neurocognitive disorder. We would like to see, because it is a rapidly progressive thing. We would like to see HIV and HIV associated any opportunistic infection. We would like to see points for is a patient is a PLHA for long period, and HIV per se can cause a basal ganglia dysfunction, and all these neurodegenerative processes also can be exacerbated by HIV, and direct basal ganglia involvement can be there, and symmetrical Parkinsonism with a chronic progressive course is there. Points against his predominant early backward falls are unusual, and early postural instability may be uncommon in the HIV-associated neurocognitive disorder. And this patient started with the postural instability, that may be an uncommon thing. And severe axial rigidity is uncommon to see in the neurocognitive disorder. Motor features usually come a little bit later into the course of the disease progression. And second thing we would like to keep is an opportunistic infections related to the HIV, because it is 1.5 year history of a relatively rapidly progressive history, and he's progressing as a patient is a HIV, and we would like to see all the treatable and possible cases of opportunistic infections. TB meningitis can be there. Points for is a TB is a common thing in India, particularly in a patient with HIV. We would like to consider the TB also upfront in opportunistic infection, because this can cause basal TB can involve any part of the brain that can involve palatal basal ganglia, or one side basal ganglia, or the base of the skull, which can cause a chronic meningitis. Then chronic meningitis can cause a NPH secondary hydrocephalus that can cause any gait disturbances, and whatever complaints our patient has, that can all be explained with the TB meningitis per se itself. And points against that, there is no meningitis features are there, and there is no history of chronic fever or headache or no other no cough or no weight loss, no constitutional symptoms are there. And cranial TB meningitis per se, if it is there, that can be indolent and or that can be present with a multiple involvement also. For the patient who has this much severity of the complaint and not having any other meningitis features or cranial nerve involvement is unlikely. And it is not an insidious, usually it is not an insidious symmetric syndrome progressing for 1.5 year. It can cause, but it is usually not a chronic insidious symmetrical syndrome. And second infection we would like to consider is a neurosyphilis, because neurosyphilis can cause a cognitive decline, and movement disorder can be are there, and it is a treatable cause also. And even if it is not a HIV patient, we would like to consider TB and neurosyphilis in a rapidly progressive patient, causing dementia, causing cognitive decline. Even though we don't keep them in the front, if it is not a HIV, we'll keep them in the last. And usually sensory and dementia pattern you'll see, and Parkinsonism features in the neurosyphilis per se is a rare. And we like to keep progressive multifocal leukoencephalopathy also. And because points for is a patient is a HIV patient with a cognitive and motor involvement, both are there. Points against is an asymmetric deficits are common in PML, and usually this have a weeks to months presentation than having a 1.5 year history of progression. And usually they will have a focal deficit. And cerebral toxoplasmosis also we would like to consider, because of it having the basal ganglia predilection, and this can cause a Parkinsonism. And usually cerebral toxoplasmosis will not cause this much chronic symmetric progression indolently. And usually this has an acute to subacute onset presentation with fever, headache, and raised ICT with full-blown presentation. It will cause seizures will be there. This is not there in our case. These are the we get lost. And we'll come to next. We'll consider neurodegenerative disorders like a PSP and MSA. And PSP points for is a patient is a 60-year-old. Usual age of onset is
just a
between.
minute, Manoj.
Sure.
The thing is, we have written in two manners, whether the HIV is causing which patient already has PLHA, patient is a PLHA person. So whether he has only the HIV and related things is caused, so they are taken that as first. But this is, we are taking the principle of parsimony or Occam's razor, that only one. But when the patient has been living with this disorder so long, patient can have additional disorders also. So you have to think about that also, whether he can have something else in this scenario or not. So that is why we are considering other disorder happening to a PLHA person.
Yes, sir.
So now proceed with these disorders here.
Yes, sir. And points for the PSP in this patient is the patient age of onset of the disease is at for 57 to 58 year. And currently the patient is 60-year-old. He has an early backward falls with a symmetrical rigidity and bradykinesia. Axial and appendicular rigidity is there. There is a hypokinetic disorder. It is a extrapyramidal speech. And early cognitive and behavioral changes are there. And within 1.5 year onset of the disease, patient started having the behavioral changes also, like in the form of apathy. And there is a rapid progression with ADL dependencies there for ambulation. He's not he's unstable to walk outside. He needs a family members to carry him, take care of him. And points against her, there is no classically against feature for the PSP. And postural giddiness is there in our patient. That is not an uncommon thing to see in the PSP. We would like to keep, currently there is no classically against feature. And gaze palsy we couldn't get from the history. We'll go in the examination. And multiple system atrophy and points for is a Parkinsonism is there with autonomic dysfunction in the form of postural giddiness. And there is a rapid progression also. And points against is falls usually later occur in the course of the disease. If not severe autonomic dysfunction, usually falls are seen in the later stage. And there are no classical cerebellar signs or cerebellar symptoms or pyramidal symptoms as per the history. And early cognitive changes are less typical. Cognitive changes can involve later in the course of the disease, but early cognitive changes is less typical for the MSA. And we would like to keep vascular Parkinsonism after degenerative because the patient is having diabetic and hypertension. And patient has a HIV that itself can cause a vascular changes, and he has a symmetrical gait difficulty. He started with the postural instability. And points against for the vascular Parkinsonism is there is no classical stepwise progression, expected stepwise progression. It need not be seen always, but there is no stepwise progression. There is no history of focal deficits. There is no history of abrupt onset of any symptom particularly. There is no usually typical backward falls are atypical for the vascular Parkinson's, and there is no clear lower limb predominant symptoms in the history. And we would like to consider autoimmune paraneoplastic encephalitis also because it is relatively okay 1 to 1.5 year history of somewhat rapidly progressive atypical Parkinsonism with behavioral abnormality also. We would like to keep autoimmune paraneoplastic encephalitis also is one of the possibilities. And points against is usually this has a subacute weeks to months presentation, unlike our patient has 1.5 year history of chronic presentation. And in autoimmune encephalitis and paraneoplastic encephalitis, seizures and encephalopathy are common. And there is no history of seizure or any encephalopathy related features in our patient. And there is no history of any malignancy, internal malignancy. We couldn't get any history like that. And we'd like to consider NPH also because of the age and gait and cognitive decline. And points against is predominant rigidity to start with the postural instability and rigidity. It's uncommon. And there is no classical triad and no urinary incontinence. This is against.
No, actually, but Manoj, your patient did have some urinary problems. Whether they are due to this syndrome or not, it's a separate thing. You may have to rule out what is the age of the patient?
60, sir.
So 60 is a bit too early, but whether it's due to BPH or some UTI, that's a different thing. But he did have some increased frequency in nocturia. Those problems he did have. So you have to be very careful. Yes. The presentation may not always be classic. Okay.
Yes, sir.
So before showing that no classic triad, we have to be careful. We will just not rule it out. Okay.
Yes, sir. And coming for the examination, the patient is a moderately built and nourished person. The pulse rate is normal. The BP is 128/70 in a resting supine position. We made the patient rest for 15 to 20 minutes, and then we check the BP. That is 128/70, and we then made the patient up. After 3 minutes of standing, we measured the BP. It is 132/78. There is no postural hypotension we could document objectively, and the respiratory rate is normal. No neurocutaneous markers and no skin ulcers or genital ulcers. And the patient also has a mask-like feces with a reduced blink rate. And blink rate is 8 for the patient, that is reduced. There is no pallor, icterus, cyanosis, or generalized lymphadenopathy or edema or any skin changes. And systemic examination is normal.
You should tell the blink rate.
Blink rate is 8, sir, I told.
You should tell that, okay?
Yes, sir. Blink rate is 8.
Please tell that, yes.
And coming for the detailed hair metal functions, MMSE is 19 and MoCA is 9. And coming to the speech, patient has a hypophonic and monotonous speech. That is a hypokinetic dysarthria, which is an extrapyramidal speech syndrome. And coming to the frontal functions, there is an impaired attention and impaired forward and backward digit span. There is an impaired attention. It's not so much impaired to for us to conduct the detailed higher mental function. Attention is okay, but when we are testing, it is impaired. Forward is 4, forward digit is 4, and backward is 0. And there is an impaired speech fluency, spontaneous speech fluency, and complex comprehension with a normal naming, reading, and simple command comprehension.
So just to be clear, he has highlighted the normal things here. Okay.
Yes, sir.
Because otherwise the slide would have become too confusing. So only few things were normal. Most of the things were abnormal. So it's a global
Yes, there is a global cognitive involvement. There is an impaired set shifting and sequencing, and there is a preserved insight for the patient. And temporal functions not oriented to the date, otherwise he is oriented to the rest of the things. Impaired, there is an impaired immediate and recent memory, and with the preserved remote memory, and there is an impaired new learning ability. And parietal function, there is a simultagnosia, idiomotor apraxia, and impaired constructional ability and complex calculation, and impaired cortical sensation.
So calculation is affected actually here.
Affected, sir. Affected. Complex calculation is affected. Simple calculation is preserved, sir. Is doing. And the occipital functions are preserved in this patient. Coming to the cranial nerve examination, all the cranial nerve examination is normal apart from the 3, 4, 6. And you can see the first video. You can see the first video. You can see the pursuits are broken in the patient.
The next time you take, please take a close-up video, okay?
Sure, sir. You can see down gaze he is able to see, but up
But I
gaze he is
think
not
still
able
we
to
can
see.
make it as up gaze and down gaze are affected here.
Yes, up gaze he is not able to see. He is having a mask-like faces, that also you can appreciate. And you can see the second video, and he's having a slow saccades, hypometric saccades are there. And other nervous system examination, he has a postural instability with a pull test positive, and he has a gait. Please see the video. He's having a slightly wide-based gait with reduced arm swing bilaterally. There is no classical pivoting. There is mild freezing at turns. Otherwise, he's bulk is normal.
What
Bilateral
is
upper
the
limb.
height of the chair which you made him stand from?
Sir?
See, the patient, the history says a strong postural instability, but here he is able to comfortably get up from the sitting position.
Yes, sir.
Okay, so that
Yes,
it is very important to start the gait from the sitting position. That is a very
Yes.
common mistake. Okay.
Yes, sir.
Now, why it is normal? See, he is able to comfortably stand. One of the reasons, maybe once you have done from this height, you can reduce the height of the chair. So we can see whether he can get up from that position or not.
Yes, sir.
So you can use a smaller stool also. So once the patient comes back, try from that also, but you have to be very careful that patient doesn't fall.
Yes, sir.
Okay. So sometimes the greater height may mask your findings. So I still think that if you reduce the height of the chair, that may manifest. Okay.
Yes, sir.
Fine.
And coming to the bulk is normal for the patient. Tone, bilateral upper limb and lower limb, cogwheel rigidity is there. Truncal and neck rigidity is also there. And power is 5/5 in all there is no weakness, no limb weakness per se. And deep tendon reflexes, bilateral ankle are absent. He is a long-standing diabetic. That might explain this. Otherwise, reflexes are symmetrically normal. And there is a brisk jaw jerk present. And frontal release signs are present. And bilateral withdrawal plantars are there. Sensory examination is normal. Cerebellar signs grossly were not there.
No. That one point I want to make here for all the residents. There are no separate signs like this. Cerebellar signs, extrapyramidal signs. These are not there. You make a list and then at the end you summarize the findings and tell that these all signs indicate a cerebellar findings. So once you go to the Bickerstaff and all the books, you will not find a heading like cerebellar signs.
Coordination.
Yes. So you have to remove these things. Okay. So coordination you will look at the end of the motor examination. NTPCA, nutrition, tone, power, coordination, abnormal movements, and special tests.
Yes, sir.
Okay. So please remove these things from your next presentation onwards.
Yes, sir.
So no, don't put any headings like extrapyramidal findings, cerebellar science. These should not be there. Then you summarize all the things along with the examination.
Sure, sir. Sure, sir.
Okay.
And coming to the summary after the examination, our patient is 60-year-old male who is a known PLHA on ART, TLD regimen for the past 25 years, and a chronic alcoholic, and a diabetic and hypertensive, presented with 1.5-year history of chronic insidious onset and progressive symmetrical appendicular and axial rigidity, bradykinesia, postural instability with recurrent en bloc falls, predominantly backwards, with gauge abnormalities and hypokinetic dysarthria, with memory impairment, impaired calculation, and behavioral disturbance in form of apathy, and possible autonomic disturbances in form of postural giddiness, without involvement of other human nerve functions, sensory cerebellar functions, and currently dependent on the activities of daily living, predominantly for the ambulation. And our differentials after the examination would remain more or less the same. In a patient with rapidly progressive atypical Parkinson's syndrome in a PLHA patient, first we would like to rule out HIV-associated neurocognitive disorder. Then comes the opportunistic infections in a patient with HIV, like TB, meningitis, neurosyphilis, PML, and cerebral toxoplasmosis, and other infections also we would like to rule out. And then we would like to keep the differential of atypical Parkinson's related neurodegenerative disorders like atypical Parkinson's related to PSP and MSA. If not the patient is a HIV, we would like to keep the atypical Parkinson's in the first place. As a patient is a case of PLHA for long-standing PLHA for almost 25 years for the past. We would like to keep HIV and HIV-related disorders in the first, and then we'll go over the neurodegenerative disorders. As a patient is having diabetic and hypertension as a risk factors and vascular and HIV positivity, we would like to keep vascular Parkinson also led. And then autoimmune and paraneoplastic others also we would like to keep, and normal pressure hydrocephalus we would like to keep. And we have admitted the patient for the same reason, and we have taken the detailed history, and we started investigating the patient further. And his normal blood count was complete blood count was normal. Renal and liver function test was normal. Thyroid test was normal, and ceruloplasmin was normal. And HbSAg, HCV markers were negative. UPDRS part 3. Syncopa challenge we did, and the pre-Syncopa challenge it was 48, and post-Syncopa it was 39. There is not much significant change, but it improved slight rigidity slightly improved, but there is no significant change. And detailed autonomic function tests were normal, and the patient is HIV positive. We reconfirmed that, and CD4 count we sent that came was 480. That's slightly reduced, less than 500, and HIV viral load is less than 82 copies per ml. And we went ahead with CSF analysis, and CSF protein was showing 159. As it is a rapidly progressive atypical Parkinson's syndrome, we would like to see as our differential first is a HIV-related neurocognitive disorder. We went ahead with CSF. CSF protein was 159, that is elevated. And glucose, CSF glucose was 181, baseline glucose was 360, that is half of it. And ADI is normal, chloride is normal. And we can see here, the total count is 29, that is cell count is elevated here, and it is of lymphocyte predominant. Lymphocyte predominant cell count is there in the CSF. And we did all the infectious workup also. GeneXpert for MTB is not detected, MTB not detected. And toxoplasma serology is there, that is IgM and IgG both are negative. And we sent for fungal culture, CSF for fungal culture also. That culture was negative. And we did the India staining for the Cryptococcus, that is negative. And we did serology for syphilis, that VDRL is positive. We twice checked it in the serum, that came positive. CSF also, VDRL is positive. In fact, serum it is 1 dilution, and CSF it is 2 dilution. 2 dilution is more evident in CSF than in the serum. Even the sample is diluted twice, it is there. Means it is more, titer is more, that means that antibodies are more seen in the CSF compared to this thing, that we can infer it. And RPR is reactive in serum, it's not reactive in the CSF. And TPHA, Treponema pallidum hemagglutination assay is equivocal in both both serum and CSF, we can see here. And we discussed with the microbiology team, they told it is equivocal, they cannot confirm currently, and they told to repeat the sample up to 4 weeks to increase the testing possibility. And syphilis indirect Coombs test is positive in serum, and at the same time it is positive in the CSF also. And we did CSF, and at the same time, as it is rapidly progressive atypical Parkinsonism, we have sent all the autoimmune and paraneoplastic also. Later on, we got the syphilis report after that. And paraneoplastic anti-neuronal antibodies in the serum we sent, and autoimmune encephalitis panel in the CSF we sent. And all the antibodies of the paraneoplastic antibodies were negative, and autoimmune antibodies are also negative. And we have sent Iglon-5 also, because it is a rapidly progressive Parkinsonism. Although this patient don't have classical sleep
And the
disturbances or
Iglon-5 can present
RBD.
like chronic protracted course also.
Iglon can have a chronic progressive course
Yeah,
also.
so there's a
Yes.
recent paper, I think, in which journal I am forgetting it. There's a huge collection of series has come which shows that Iglon 5, how they behave. So there is around 20-30 patients are there, I think. So that has shown it is not like one-to-one, even despite giving the immunotherapy, they may not respond sometime.
Yes.
So Iglon 5
And
behaves differently from the other autoimmune illness.
we
Sleep
did
was
the
also normal
CECT.
and this antibody is negative here, yeah.
Yes, sir. And CECT thorax abdomen we did in a purpose to evaluate for a rapidly progressive atypical Parkinson's syndrome in a patient with HIV. We want to see for the TB also, and no evidence of malignancies or TB. We observed to CECT thorax abdomen was normal completely. And we did an MRI, and you can see here MRI was showing it is a sagittal section of FLAIR MRI, and we can see the flattening and concave outline here in the midbrain. This is a midbrain, this is a brainstem. We can see here. This is a midbrain, this is a pons, and this is a medulla, and this is a cerebellum. This mild atrophy is there in the all the lobes. I'll show in the axial cut. In this sagittal cut MRI, I would like to show you there is a concave outline in the superior aspect of the midbrain, which should be ideally a convex one. Here we are seeing the concave thing, like in a penguin sign, like in a penguin sign. There is a concavity upward here, and there is a hummingbird sign. Both are equivalent signs. There is a hummingbird sign. You can see the concavity upward. This is a sensitive sign for the PSP. This is a sensitive sign for the PSP, which shows that is a superior midbrain atrophy. And coming to the other signs, we found Mickey Mouse sign and morning glory sign. Both are relatively equivalent. And morning glory sign is a splaying, loss of lateral convex margin. Splaying or loss of lateral convex. Usually this should be like this thing. The loss of convex will become concave. This became concave margin of the tegmentum of the midbrain. This is resembling the morning glory flower. You can see here. Because of this thing, it got a sign of morning glory sign. That basically it says a lateral convex margin that convex margin is formed instead of concavity. And you can see it resembles a Mickey Mouse also, the two hair plugs to the midbrain structures. And actually, basically, there is a reduction of the anteroposterior midline midbrain diameter that gives this sign, along with the lateral convexity margin. And this is an MRPI, MR Parkinson Index. Here, what we say is we will measure
Your patient
pons.
had cortical atrophy also, right? Global cortical
Yes, sir.
atrophy.
Yes, sir. I'm going to show that also. He's having a
Okay,
cortical
fine.
atrophy. You can see here, little. He has a knife edge atrophy in the temporal also. I'll show the
Because
frontal
we
also.
have a slow cognition along with the frontal lobe
Yes.
dysfunction, along with the
Yes.
episodic memory loss, which indicates a temporal dysfunction.
Yes, sir.
The dyscalculia, other things which for parietal, and we are, I think, only the posterior
Yes, sir.
segment should be preserved. Yeah.
Yes, sir. Yes, sir. And here, going to the MRPI, it is even more sensitive thing for the PSP. How? Because we are calculating area of pons by midbrain. Pons area by midbrain we will calculate, and middle cerebellar peduncle by superior cerebellar peduncle we will calculate. Usually in a PSP patient, MRP indexes will be more than 13.5. This is sensitive and specific also. Why? Because we are calculating pons area to the midbrain area. That means that in a PSP with a severe postural instability interval, we expect a midbrain atrophy with relatively preserved pons. Here we can see pons area is preserved. Unless there is a reduction in the midbrain, this ratio will increase. When there is a reduction in the midbrain, this ratio will increase. And superior cerebellar peduncle is related to the midbrain. When the midbrain is atrophied and associated superior cerebellar peduncle is also atrophies. And corresponding pons is preserved, and middle cerebellar peduncle will get this pons pathology if it is preserved, and this also will get preserved most of the times. And similarly, when there is a diffuse pathology involving entire brain, and at that time pons area also will reduce, pons also will shrink in size along with the midbrain. This ratio will not change much. And in a PSP, predominantly affecting the midbrain particularly, when the midbrain area is reduced, P by M ratio will increase. And MCP and SCP, when this ratio is increased, that shows the superior cerebellar peduncle is involved and atrophied. That also shows an indirect sign of midbrain involvement. This
Manoj,
ratio,
basically what we're trying to show is that this ratio will increase if midbrain and
midbrain atrophies are
just a minute, midbrain and the
superior cerebellar peduncle
superior cerebellar
atrophies.
peduncles are selectively atrophied.
More than the
While
pons and middle
pons
cerebellar.
and MCP are spared. In that scenario,
Yes, sir.
so at the level of pons, there is pons and middle cerebral peduncles. In the
Yes, sir.
midbrain level, there is middle cerebral peduncles and a superior cerebral peduncle. So in
Yes.
this pathology like PSPs, midbrain and superior cerebral peduncles are gone. Pons and middle cerebral are preserved. So this ratio will increase, right? Because both pons and MCP are in numerator. The other
Yes.
two things are in denominator. Okay.
Denominator. And here we can calculate in an imaging we can see and calculate like pons area will get by length into breadth into height. We'll measure that by 2. We'll get the pons area. And similarly, midbrain also we'll calculate length into breadth into height. We will calculate, and we'll get the LBH by 2. Use the midbrain area. Then middle cerebellar peduncle in a sagittal section MRI we will see here. In the coronal section we will see the superior cerebellar peduncle. That is calculated like that. They gave the MRP index. They formulated with the to calculate the superior cerebellar peduncle, particularly in the coronal section, and middle cerebellar peduncle, average width of middle cerebellar peduncle in a sagittal section. They formulated the index like that and they calculated like this. And they found more than 13.5 is an indication of is indicative of relatively specific and sensitive for the PSP syndrome. And the value here in our patient is 39. That is very much well above than the 13.5. That is significant. And we did a contrast. We did a contrast enhanced MRI also, and this is actually done after the lumbar puncture. And he has a slightly uniform enhancement of the right cortical and right cortical parietal and occipital area. And we can see, I'll play the video of contrast enhanced MRI. Please do.
Yeah, but it's a common mistake that MR is done after the lumbar puncture, immediately after lumbar puncture, which can show enhancement. So MR should preferably be done before the lumbar puncture is done. So this is, I think this was done within 48 hours of this thing.
Yes, sir. Within 48 hours we did, sir.
Lumbar puncture.
And yes, sir. And thing is, plain MRI only we did.
Okay.
Plain MRI only we did initially. There was no gross lesion or space of pain lesion or any mass-like thing we did. We found, and they concluded with the plain only. And after the CSF abnormality only, we had to go for the MRI contrast. And then after MRI contrast, we found this thing.
So especially the contrast and MRI should always be done before the
CSF.
CSF.
This patient has slightly symmetrical right and left is there. And the patient has atrophy of the frontal and temporal and parietal also. The areas are symmetrically atrophied. With a relatively preserved pons, you can see the pons and midbrain, relatively preserved cerebellum, medulla, and pons also. With sudden atrophy of the midbrain, gross atrophy of the midbrain, that is also there. And there is a temporal atrophy, frontal atrophy. And coming to the, we did in our patient, serology for syphilis is positive, and a lot of tests are positive for the patient, and the sensitivity for VDR and RPR is relatively very specific for the sensitive for the syphilis, detecting syphilis. VDRL and RPR has a sensitivity of 78 to 86% in detecting primary syphilis. At the same time, 100% for detecting secondary syphilis, and 95 to 98% sensitivity for the detecting secondary syphilis. And FDA apps, which we couldn't do in our patient, has a sensitivity of for a primary 78 to 78.2 to 100, for a late and 84.2 5 to 92 also has a specificity from 87 to 100%. And microhemagglutination assay for Treponema pallidum also has a relatively similar specificity, 98 to 99. And comparatively, TPPA, Treponema pallidum particle agglutination, which we did in our patient, has a better sensitivity, nearing to 100%, and better specificity also, 99.6 to 100%. And this thing came equivocal in our patient. We would like to see in future that we want to repeat after 1 month. And course in hospital, we consider the diagnosis of rapidly progressive atypical Parkinson's, PSP-like syndrome with a neurosyphilis, and diabetes and hypertension with a PLHA, with HIV positivity. And we treated the patient with aqueous penicillin IV for the 14 days, 4 million units IV fourth hourly we gave. And we gave supportive medication for the diabetic and hypertension with the blood sugar and hypertension monitoring in the ward. We gave gait and balance training in the ward. We trained the patient attendant also, wife also we trained. We gave counseling regarding the nature of the disease and associated infection and all the complaints. We attended all the complaints. And planned discharge, we recently discharged the patient just before 20 days only. We discharged the patient. Our planned discharge is to repeat assessment at the 3 months again. We gave treatment for IV aqueous penicillin for 14 days. We want to assess the patient again after 3 months. And to repeat the CSF and serum syphilis testing at 3 months also. We would like to see whether this is persisting. And we would like to repeat the TPHA, treponema-pallidum hemagglutination assay, that will agglutinate the direct bacterial antigens rather than this VDRL. VDRL may be positive in the patient who got treated also completely. And VDRL positivity may be there in that also. Or RPR also, these are antibody testing and all. This can be positive in the treated patients. We want to see the treponema-pallidum agglutination, hemagglutination. We want to see the antigen particles we want to see. And coming for the neurosyphilis, this is a great mimicker, and this is caused by treponema-pallidum. Neurosyphilis can occur at any stage of infection of the syphilis, and this has a tendency to involve meninges, blood vessels, brain parenchyma, anything it can involve in the brain. And proposed mechanisms of Parkinsonism is in the neurosyphilis is per se direct basal ganglia involvement, or chronic meningovascular inflammation and chronic meningoencephalitis, and chronic immune-mediated pathologies also are described in the literature, and neurodegeneration and network dysfunction also can be there. And our patient is an immunocompromised host with a chronic progression with a combination of extrapyramidal symptoms, chronic dysfunction with the strong CSF and serum VDRL positive and RPR positive, indirect Coombs test positive, with the CSF pleocytosis is there, and cell count is 30 with abnormal protein in a patient with HIV. We want to definitely treat the patient who have all this test positive for the syphilis before going ahead and labeling it as degenerative. And coming to the next slide, this is a spectrum of systematic review by Dr. Ravindra Kumar Garg et al. Published in January 2026 this year. And spectrum of movement disorders in neurosyphilis is a systematic review. Here they analyzed a total of 48 individual cases from 44 publications. These are and 2 retrospective cohorts also involved with total 61 movement disorder patients. And here they found total 48 patients are there. In them they found 76% are male and 76% are HIV negative. And movement disorder subtypes included were ataxia is a commonest one, that is 28.9% has ataxia as a movement disorder in 48 patients, and Parkinsonism is seen in the 18.4. And coriform disorders are there in 15.8, and dystonias are seen in the neurosyphilis patients of 15.8 patients, and myoclonus is 7.9. And orofacial candy sign, orofacial lingual candy sign is seen in 7.9. Orofacial candy sign means that having the involuntary movements at oral and facial lower half of the face and tongue that resembles like a person who is chewing a candy. He is eating a candy, swallowing a candy. That movement is there, and that is literally pathognomonic for the neurosyphilis. And in 10 cases, complex presentation that mimicked the PSP and corticobasal degeneration. And here in the study, with 38 patients with movement disorder, and serum serology positive for 36 patients. Serum is positive for 36 patients, negative for the 2 patients. In our patient, serum is positive. CSF serology positive for 32 out of 38 patients. CSF also is positive in our patient. And pleocytosis is there in 30 out of 38. Our patient had 29 cells with a protein is 159. Protein elevated in 28 out of 38. We have protein elevated here in our patient also. Glucose low or mildly reduced. We have mildly reduced glucose. It's not significantly reduced. And the type of movement disorder or ataxia noticed in the study in this current review of literature was in the patient with 38 patients was 7 patients out of 38 had Parkinsonism symptoms. Parkinsonism, like any that was not described like any, not classically described like PSP, whether it is atypical or typical or IPD, anything. Here they have Parkinsonism seen in the 7 patients out of 38. Ataxia, any form of ataxia, like is seen in the 11 out of 38. And orofacial orolingual dyskinesia, so like a candy sign, is seen in 3 out of 38. And they also mentioned mixed or complex presentation, like a complex Parkinsonism with ataxia, 2 out of 38. Marcus Gunn jaw winking synchronicity is there in 1 out of 38. And vertical supranucleus gaze palsy alone as an extraocular movement disorder seen in 1 patient out of 38. And other clinical features they noted was cognitive and behavioral abnormality seen in 22 patients, that is 57. Like half of the patient had cognitive abnormality. Our patient also had. Cranial abnormalities there in 14 patients. We don't, our patient don't have otherwise from extraocular movement abnormality. Speech or language disturbance is there in 15 patients. Cerebellar incoordination there in 13 patients. Sensory complaints are there in 7. Seizures are there in 2 patients. And neuroimaging is there in, like brain and cerebellar atrophy is there in our patient also. And it's not normal in our patient, like normal MRI also there in the 7 patients out of 38. And there is no hydrocephalus in our patient. And autopsy pathology abnormal in 1 patient. And comparatively, outcome of the neurosyphilis after treatment, marked or complete improvement there in the 17 patients, like 44.7. Nearly half of the patients had a marked or complete improvement. Partial improvement there in the 13 patients, that is 34.1. That means after treatment, relatively 77% of the patient had become better after the treatment. That's why it is even when we are in doubt of whether it is confirmed, whether we are confirmed or not, when we are in doubt of syphilis per se, it is better to treat the patient. And death occurred in 2 patients.
Did you
And
find
they
the risk
proposed
factors that early treatment start and all those things will affect the outcome? Did you find some out?
No classically
factors?
described, sir.
Did you find any prognostic factors?
Prognostic factor, but per se, I didn't find anything, sir.
Okay.
With the treatment, patient became better. This is the article I got.
But it makes a logical sense that earlier the treatment you start, earlier the
better.
thing was given the better outcome.
Yes, sir. And the proposed pathogenesis of movement disorder is a basal ganglia dysfunction seen in the 12 patients of 38. Cerebellar involvement is there in 8 patients. Meningovascular neurosyphilis 6, and other mixed mechanism in 3 patients.
Again, the midbrain is not done here.
Sir? Midbrain they didn't mention here. Mixed mechanisms are discussed. And neurosyphilis can present like a classical distinct neurological syndrome like a PSP, CJD, anti-NMDR, CBD, and NPH like presentation. Or a hyperkinetic disorder like a tremor, dyskinesia, choreoathetosis, hemibalismus, and myoclonus. Or a hypokinetic disorder like a PD and dystonia. Or a classical isolated cerebellar syndrome like a pure cerebellar ataxia with the tremor and gait instability. Or a combination of either of these. And proposed pathogenesis is direct infection or invasion of the bacteria per se that can cause, or vascular mechanisms like endarteritis, obliterans, and vasculitis per se can cause. And immune-mediated inflammatory injury can cause a neurosyphilis, driven neurodegenerative pathology. And mixed or complex mechanisms can be there, and toxic metabolic and secondary effects due to the syphilis per se can be there. And this is another article by Louis Philippe Denner et al. Parkinsonism in HIV infected patient during the antiretroviral therapy. And they have taken 249 records. Where among the 249 patient records, they identified 4 individuals reported Parkinsonism symptoms after the HIV diagnosis. 3 of them had no other identifiable cause of secondary Parkinsonism. All the symptom onset before the age of 60. For a patient to usually Parkinson's disease, typical Parkinson's disease, usually age of later onset, like above 70 years. When we are seeing before 60 in a patient who started with antiretroviral therapy with a HIV diagnosis, that they found that HIV infected individuals might be at a higher risk for developing Parkinsonism as a manifestation of early neurodegeneration. And this is a 3 case reports and by Resado and Caprara, Parkinsonism plus syndrome secondary to neurosyphilis. They published this thing. And 3 syndromes, 2 cases were first and third case was the PSP and second one was a CBD-like presentation. And all the 3 neurosyphilis serology is positive, VDRL is positive, RPR is positive VDRL and FTAFs. And the CSF abnormal is there in the second and third case. And they followed up, they treated the patient, they treated with penicillin G, IV penicillin G. And at first case, 3 months showed a slight improvement in the walking, speech and alertness was there. And second case, at 3 years, improved mental status is there. And third case, at 6 months, patient had a full recovery of her conjugate eye movements and cognitive functions. And take-home points, and the coexistence of dual pathology is possible. And degenerative PSP, that can be there along with subclinical neurosyphilis, that can be a possible entity. And difficult to tell which is driving the pathology in the brain and which exactly caused, we cannot tell. And we have to treat and watch. When we are in doubt, we have to treat and watch for the development of symptoms. When our patient gets better with the treatment after 1 month and second month and third month, we are going to reassess him. And if he gets better, we can attribute strongly to neurosyphilis per se. And we cannot still further rule out degenerative PSP. And in a patient with PLHA, always rule out secondary causes like infections, metabolic and vascular. But avoid bias toward the infections. And if infection is there, we must not miss that. We must try to not miss it. And when in doubt of infection, we should reinvestigate and treat it accordingly. Thank you.
Thank you, Dr. Manoj.
Sir, here we presented 2 cases, sir. One was ACHR positivity and second was neurosyphilic tests, all the CSF and serum tests. So here the HIV was also, copies were also present, and the HIV in CSF and the CD4 counts were also reduced in this case, in addition to the abnormal CSF. So all this, like the idea of combining these 2 cases was like how the diagnostic tests can lead to a lot of challenges in the management. But we hope that in the 3 months, 6 months, we see some response in this case. PSP is extremely rare, very, very rare in the literature, like only few case reports we could find. So we would like to hear your comments, sir.
When we were students, PSP phenotype, neurosyphilis was one of the important differentials. What was important, in every case of PSP, we are expected to look for the Argyll-Robertson pupil, the Abadie's sign, the depressed ankle reflex, and the testicular sensations. Because the falls in neurosyphilitic PSP is dual. One is posterior column because Tabes coexisted with them, and second was third thing is the midbrain was the seat of neurosyphilis. So we are expected to tell when we were in the pre-HIV era, when we were doing our MD general medicine. So PSP phenotype, one of the important differentials is neurosyphilis.
But surprisingly, in the literature, it is very rarely shown. The way you are telling it looks like
when we were students, the Professor we understand those times which in every PSP phenotype, our professor, my teacher Vijay Rangan used to insist on this. And second, after the advent of HIV also, the direct involvement of can damage substantia nigra, and not only that, the chronic HIVs can add alpha-synuclein deposition there, facilitating the buildup of alpha-synuclein in the basal ganglia. So in the overlapping era where there is the initial phases, we saw a few extrapyramidal cases that are coexistent of neurosyphilis and HIV, because the promiscuity overlaps. They're coexistent of neurosyphilis and HIV cases in the early period of HIV, where a lot of cases were there. In fact, I remember one of my colleague did a PhD in, the colleague did a thesis in CSF, EDRL, and HIV status together and neurological manifestations, and in as early as in 1990s. This was 93, if I remember correct. There was a thesis on that. So anyway, once again, excellent presentation, Manoj. I really thoroughly enjoyed the presentation, and
Thank you, sir.
case was excellent and very well worked up. And again signifies that keep searching for a treatable cause in every degenerative case. The motto for the neurologist is never brush it aside as neurodegenerative. More and more evidences are coming that microbes play a major role in unmasking the neurodegenerative and attacking the microbes, like, for example, varicella. Varicella association with stroke is now coming up in a large way. Varicella has major role in many other neurological disorders. So time is not far away. The entire debate of microbes triggering neurodegeneration, or they point out, see the very fact that CJD had prions. Similarly, there may be any number of viruses which can trigger or precipitate a neurodegenerative process, and attacking primarily the microbes could always, microbes or a treponeme or any of these microbial organisms would definitely benefit. Wonderful presentations from the Department of Neurology, JIPMER. My hearty congratulations to you. So, Professor VN, sir, you are there to conclude, sir? Probably sir is not there. Anyway, thank you. Thank you so much, Vaibhav. I think
Yes, sir.
we are
Finished in
5
time also, sir. 5 minutes early.
Yeah, not only that, any question, chat, the questions has already been answered. All the chat questions have already been answered. Thank you so much for Manoj, Dr. Saranya, and Dr. Vishnu.
Thank you, sir.
Thank you so much, sir, for the chance, sir. Thank you so much.
Thank you, sir.
Thank you, sir.
And I would be requesting you, whether this is the same thing, Dr. Vaibhav will talk to you and call me back so that we can do it this Friday in the national scenario. Thank you.
Okay, sir. Thank you, sir. Thank you for the chance, sir. Thank you.
Thank you, sir.
Thank you.